Good afternoon, everyone. First, at the outset, I would like to thank Professor Dr. V.Mohan, Dr. Anjana ma'am, and Dr. Ranjit sir for giving me this opportunity. Today, I am going to talk about PCOS and diabetes. Polycystic ovarian syndrome was described in 1935 by Steen-Leventhal, and it is also known as Steen-Leventhal syndrome. While making the diagnosis of PCOS, we have to be careful to rule out other conditions having similar symptoms like thyroid disease, hyperprolactinemia, non-typical adrenal hyperplasia. Though a common clinical entity, it is often underdiagnosed. Normally, a pulsatile gonadotropin releasing hormone comes from the hypothalamus and causes production of luteinizing hormone and follicle stimulating hormone in equal proportion from the anterior pituitary. This acts on the ovary, and luteinizing hormone acts on the thecal cells of the ovary to convert cholesterol into androgen. The FSH acts at the granulosa cell level and converts androgen into estrogen. This causes ovulation. After the release of the ovum, corpus luteum secretes progesterone. This will have a negative feedback and controls the GnRH secretion. This is how the normal hormonal balance is maintained. But in PCOS, there is an increased GnRH production causing an elevated LH and a reduced FSH, leading to androgen excess. Because of the reduced FSH, ovulation does not happen, and corpus luteal formation and progesterone secretion are inhibited. So the negative feedback of progesterone on GnRH is lost, and this leads to the hormonal imbalance that we see in PCOS. Coming on to the clinical features, there is menstrual irregularity like oligomenorrhea or amenorrhea due to chronic anovulation. Hyperandrogenism presents as acne, hirsutism or alopecia. The immature follicles appear as cysts on the surface of the ovaries, giving a polycystic ovaries. Overweight or obesity is present. Moving on to the metabolic abnormalities of PCOS, there is insulin resistance with hyperinsulinemia, impaired glucose metabolism, type 2 diabetes, metabolic syndrome including obesity, dyslipidemia, hypertension, cardiovascular dysfunction, NAFLD, and sleep apnea. When we see the epidemiology, clearly the amount of presence of diabetes including impaired fasting glucose, impaired glucose tolerance and diabetes is more in patients with PCOS compared to normal individuals. The link between PCOS and diabetes. As shown in the previous slide, there is a 4 times more risk of developing diabetes in PCOS, and there is an early onset of diabetes as well as pre-diabetes in patients with PCOS. The exact relationship between the two is not a clear, straightforward one, and lot of research is going into it to understand the association better. But obesity and elevated testosterone causing hyperinsulinemia and insulin resistance is the probable association we know as of now. Coming on to the pathophysiology of hyperinsulinemia, insulin, which is produced from the pancreas, causes increased androgen production through steroidogenesis. This causes a negative feedback on the hypothalamus and pituitary gland, causing an hormonal imbalance that we see in PCOS, producing anovulation as well as a decreased insulin sensitivity. This results in insulin resistance and hyperinsulinemia, further stimulating the cecal cells to produce the androgen, and this vicious cycle continues, resulting in insulin resistance as well as hormonal imbalance in PCOS. Coming on to the diagnostic criteria, PCOS is diagnosed with the Rotterdam criteria, which includes oligomenorrhea or anovulation, hyperandrogenism and polycystic ovaries. The presence of 2 out of 3 confirms the diagnosis. Hormonal panel that we have to do are LH-FSH ratio, testosterone, prolactin and TSH levels. Diabetes can be diagnosed by doing fasting plasma glucose and HbA1c, but the gold standard is to do an oral glucose tolerance test. So the key is screen early for glucose intolerance in PCOS. Coming on to the management, the mainstay of treatment starts with lifestyle modification, having a balanced diet with a low glycemic index food, regular exercise, weight reduction of more than 5%. Hormonal contraceptives can be used to correct the menstrual irregularities seen in PCOS. For management of diabetes, insulin sensitizer like metformin is the drug of choice, and it has been used for many years, followed by DPP-4 inhibitor, which improves insulin sensitivity. SGLT2 inhibitors and GLP-1 receptor agonists can be used to manage obesity and thereby have a better option in PCOS. While using GLP-1 receptor agonists, it is better to choose the patient profile, especially if they are obese and have more features of metabolic syndrome. Ovulation can be induced through drugs like clomiphene or letrozole, and in advanced cases, IVF can be done. Anti-androgens like spironolactone can be used to treat acne and hirsutism. So the final clinical pearls for the diabetologist here. First point is PCOS and diabetes share a common metabolic root, that is the insulin resistance and hyperinsulinemia. Oral glucose tolerance test is the gold standard for diagnosis as well as follow-up. In obese PCOS patient, there is a high risk of diabetes, hence they have to be screened periodically. A timely diagnosis with lifestyle modification will help to reverse or halt the disease. A balanced diet with regular exercise is the mainstay of treatment. Maintaining an optimal weight helps to prevent diabetes. Metformin, DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists can be used to manage diabetes. Public awareness, early screening and access to appropriate treatment, including the reproductive abnormalities as well as metabolic abnormalities in PCOS, is very essential. And thank you for the patient listening.
Thank you.